Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
Hello and welcome to our discussion on monkeypox. This will be an interesting conversation. I'm Leanna McGuire, your host for this Elite Learning podcast, and our guest is Dr. Daniel Griffin. Dr. Griffin is a physician scientist, board certified in internal medicine and infectious disease, with expertise in global health, tropical medicine, parasitology, and virology, including SARS-CoV-2 or COVID-19. Welcome, Dr. Griffin.
Oh, thank you so much, and welcome everyone to today's session.
Yes, this will be interesting. Can we start from the very beginning? What exactly is monkeypox?
Yeah, so, I think people first ask, what is this? What's this name? What's this all about? So first off, this is a viral disease. So it's a virus. It's transmitted through contact. It's described as one of the pox diseases where you actually see these pox, these vesicles. And the name is historical. The name's changing, but it gets this name because back in the 1950s it was actually recognized in a colony in monkeys in Copenhagen in Denmark. We didn't actually see the first cases in humans until about 1970, or probably the better is to say we didn't recognize cases in humans till about 1970. So it has this historical name. It's now, the WHO has suggested, and I'm going to sort of agree with them, renaming it Mpox, sort of getting rid of what they are concerned is a racist, stigmatizing name. So, there'll be a transition period. A lot of the literature, right, still will have the term monkeypox in there. But over time, this will become Mpox. But yeah, that's what it is. It's a virus disease. It's an infectious disease. It's a disease that is predominantly transmitted through contact that manifests as these pox, these vesicles, these pustules.
So originally it was a transfer from monkeys to humans, is what you're saying, or they saw it in monkeys at one point? Just to clarify.
That's a great question because that really leads into, so what's the reservoir? Where's the Mpox virus usually residing? The suggestion is it's probably in rodents, and the monkeys, just like us, a zoonoses. It was sort of interesting, zoonoses probably rodent to monkey, rodent to us. So we don't necessarily think that people got this from monkeys. The suggestion is the monkeys, just like us, got it from rodents. And then there are probably these rodent reservoirs. And we've even run into that here in the United States. Actually, one of the introductions about 20 years ago was in the exotic pet trade, where in an exotic pet, I guess you'll call it a pet, a little rodent that someone was going to have as a pet was brought into the country, and we had an outbreak. It actually got into a prairie dog population, and then we had that rodent prairie dog transfer to humans. So the reservoir is probably a rodent pox, so a little bit of a misname. So Mpox is probably going to be a better referent going forward.
Yeah, that makes sense. But not everything can be transmitted from one species to another, correct?
No, and that's one of the challenges. I mean, the viruses, the pathogens that come to attention are those that can. But most pathogens are not as we say promiscuous in infectious disease. They're kind of stuck within their particular host. But as we saw with SARS-CoV-2, as we've seen repeatedly with the Mpox virus, it can actually infect several mammalian species.
It's really interesting. So who should be concerned? Does this target any specific demographic, or is it whomever?
Yeah, so the timing of when we're recording this, I think, is important to give a context here. So Mpox is something that has been endemic in sub-Saharan Africa since we recognized it in 1970. So, there continue to be cases, there continue to be outbreaks. There was a little girl whose care I was involved with prior to our outbreak in the U.S. in Ghana, little newborn girl, just covered with the Mpox pustules.
wow.
So it's an ongoing thing in sub-Saharan Africa. What we saw recently in Europe, the United States, in the spring and into the summer of 2022, was an introduction, probably through a particular demographic. So, men having sex with men, a number of these events, a number of these festivals. It started in that population. A large number of the diagnoses were in that population. But as I'll point out, not all the cases were in that population. So that was a group that had a lot of contact that we recognized and diagnosed and treated a number of cases. But we also saw cases in women who are not men having sex with men. We saw cases in children. And actually what we realized with some recent literature is we probably missed thousands of cases outside of that demographic, the men having sex with men. And in the most recent study of women who got monkeypox or Mpox, about a third of them, there was no obvious sexual contact. It was not sexually transmitted. It was a contact transmission. And the children, again, those were contact transmission cases. So there was a population that saw the bulk of it. That population actually had the highest rate of, early prompt diagnoses. But who should worry about this? Well, no one should worry about this, but I think we should be aware. We should be alert. In the United States and Europe, the number of new diagnoses has really dropped down to about a dozen, about 10 or so per day. So really tremendous compared to seeing that many every single day in New York City in the early days, for the entire country, that really dropping down. But no, it's important to realize that it's not restricted to a certain population.
That's good to know, because we do hear a lot of, I don't need to worry about that because it's only gay men, was a popular misconception. And so it's contact, you said, is how it's spread.
It is primarily contact. And I think this is important. And very few things in the world are strict binaries,
Sure.
That's funny. This is this circular, where you say, nothing is 100%. And I'm claiming that statement is true. But 99% of the time, we believe that the transmission is through pretty significant direct contact. There are certain circumstances where there may have been some sort of respiratory transmission. So we tend to be incredibly careful when these individuals are in the hospital or in other settings to really prevent that low likelihood event, but that possible event.
Gotcha. Okay. So you're saying approximately 10 per day, did you say?
Yeah, we're down to about that. I mean, we have about 30,000 diagnoses so far, confirmed diagnoses in the United States of Mpox. And that was really peaking early in the summer of 2022. That really has dropped down. We continue to see a few cases diagnosed per day, and we do suggest that we're not diagnosing every single case. And we'll talk a little bit about that because, some cases, hit you over the head. Like I described that young girl just covered with these umbilicated pustules. So pustules with almost looks like they have a belly button, each one of them. Two, what can just be a painful rash, maybe in the groin area, and not even sure what that is. Some of these young men, suggesting that they now have adult onset acne in their 30s, which they don't have. So there really can be quite a spectrum here. Some very obvious, some quickly diagnosed, some maybe because of bias, the diagnosis is significantly delayed.
What are the other symptoms aside from the pustules?
Yeah, I mean, one of the things about this introduction into the U.S. and Western Europe is we saw a broader range of presentations, right? So the initial idea was that you started off with a febrile illness, then you would start to develop a rash, and it was really this defined progression. We actually saw in this case half the people didn't have that fever. Half the people started to have a rash first before they had any systemic issues. So you can have fever, yes or no. You can feel sick or not. You can have enlarged lymph nodes or not. You can have a rash. I mean, the rash is almost uniform because that's how we think of it and diagnose it. So there may be manifestations without an obvious rash, but typically there's that rash. And then the rash, we had said before this that it would go through various stages of development, but that it would actually be some of them at the same time. So chickenpox, you get vesicles, they're all at the same time, all in the stage of development, and then they would scab over. Classically, what we had said about Mpox is that you might have vesicles and pustules at the same time, but the reverse is true. With Mpox, you can have all vesicles, all pustules, all at the same time as well. So the manifestations are so broad that really the takeaway that we've said to clinicians is if it's a vesicular rash, if it's anywhere in your differential, you got to test because that's the only way to tell whether or not it's Mpox. And I'm going to throw this in, you could have more than one thing. And about 30% of people that were diagnosed with Mpox had something else also. So this approach of like, I will find out that it's, that's HSV and then I'm done. Well, the fact that it's HSV does not tell you that it's not also monkeypox or Mpox.
Interesting. I can see how it was misdiagnosed for sure. So how is it tested for now?
Yeah, so there's basically a way to test it. I'm going to say there's two ways that this can be procured, but we're using swabs. So these are those non-cotton large tips that we use. You rub the lesion to unroof it. Early on, there was a suggestion that you might use a needle to unroof it to get at that fluid. We've said stop doing that because there's been some issues where people have poked themselves with those needles. So no sharp objects. It's recommended that you use 2 of these. You're going to rub those lesions, get that fluid once you've unroofed it. And this is a little bit of a challenge because those roofs can be a little bit thicker on an Mpox vesicle pustule than they would be on some of the other viral rashes. And then you're going to put those into the liquid viral transport medium. And the split here, which I think is really nice, is they looked at, can people do this? Patients do this? Do you need a board-certified, infectious disease? No, you do not need a board-certified infectious disease physician. Patients can actually swab the lesion themselves, drop it into the liquid for you, same sensitivity. That specimen is then sent off for PCR, which I think we've all gotten familiar with. And that PCR is very sensitive, very specific for this diagnosis.
Do you see home testing in the future?
Probably not quite yet. There is some development, antigen testing, right, which would be amenable to that. Swabbing those, putting them in a liquid, dropping them onto a lateral flow, like those home COVID tests. I'm a huge fan of people, able to test themselves. We'll see. And part of the challenge, right, is that this is dropping to low numbers in the U.S., dropping to low numbers in Europe. When diseases start to drop to low numbers in high resource countries, we start to lose the focus on those limited resource areas that are still in the middle, that continue to be in the middle of Mpox spread.
Interesting. Any issues or concerns about mortality related to this?
That was one of the good things I will say about the Mpox spread. There were very few deaths. Less than 10, maybe about a half a dozen that were people that died either with or from Mpox. Tended to be immunocompromised individuals. But no, by and large, though, this can be a horrible disease as far as pain and suffering. Sometimes the pain and suffering being so severe that people need to be hospitalized, people require narcotics. They may not even be able to eat or drink, but your chance of dying from Mpox is very low.
Okay. And the pain from the pustules, or is it joint pain, or where's the pain?
So the pain is most often where the rash, where the skin lesions are. So sometimes if that's like in a rectal area, it can be horribly painful. Sometimes on the face, and not only can it be horribly painful, but the inflammation can be so deep it can actually lead to scarring of these areas.
Wow. Ouch. Are we aware if there are any long-term effects of this that we should be aware of?
Yeah, is there a long Mpox? Is there a post Mpox syndrome? you would think we would know, right? As I mentioned, it's first described 1970 in Africa. Number of recognitions since then. We should have really good data on this. Unfortunately, we don't. So in the next months to years, we'll be following a lot of these individuals, seeing if there's a post-infectious sequelae syndrome.
Okay, interesting. Okay, so the presentation, it's not typical. Everyone doesn't present with the same thing initially, like you said. Some will have fever first or...
Yeah, I think that's really critical, right? And maybe we
Sure.
learned that from COVID-19. The way that you tell what viral syndrome, what viral infection you have is by testing. There are many more atypical presentations. The virus doesn't read the textbook. So we need to continue to be aware. And that's one of the challenges, right? As you drop to lower numbers, it's another test. Do I really need to think about this? And yes, because, if we don't, the suggestion is that this is something that's going to be around, that's going to periodically spike, maybe during summers when there's more contact. And if we're not ready for it, then it'll get ahead of us and we'll start to see this spread.
Okay. Now, would this be something that is routinely, not routine, but tested in the ER, for example? Would they be doing that with people that present with any kind of related symptoms, or is it just not enough cases to make that a routine?
There was a time there when it was really, I'll say, rampant here in the tri-state area, seeing lots of cases that I would do weekly discussions with our urgent care centers. And it still continues to be part of our workup for someone who comes in with a vesicular rash. And I would suggest that should continue. Will it continue? Will it continue in busy emergency rooms once the case numbers have dropped really low? Probably not. There will be questions about how cost effective that is. But that's going to be the challenge going forward. We don't want to miss cases and then have that individual spread it to family members, friends, family, other contacts.
Okay. Is there a vaccine? Will there be a vaccine? I know
there are vaccines.
Okay.
A couple, the traditional smallpox vaccine, but there's also this Ankara Jynneos vaccine. Also out of Denmark, so interesting enough. and it's actually quite well tolerated. Over 1 million doses have been given out in the United States. It's a 2-dose vaccine. And we are getting pretty good data on efficacy here. It looks like there's effectiveness at preventing disease. It also looks like there's really good B-cell memory response here. So there may be a durability. So we're hoping that this continues to be an effective tool. It looks like it's an effective tool. But yes, there is what we think is a safe, effective vaccine. We now do not have vaccine shortages. They're in plenty of supply. We should be ready for what we describe as a ring vaccination, for when we see the next number of cases.
Okay, so it would be in the presence of. Do you see it as being something that children are vaccinated for, like chickenpox, or would that be CPOX?
So I think that's a great question. Where does this fit in? Is this going to become a routine childhood vaccine? At this point, the thought is no. Is this something that all healthcare workers will get? Well, with 10 cases in the entire country per year, maybe not. Now, the other reason why this is not so essential as a routine vaccination is you can get vaccinated post-exposure. So if you take care of an individual comes in, they test positive, you can always start your vaccination series at that point, and it looks to be efficacious. So we still have that as an option. And that actually happened several times this last summer when healthcare workers were exposed. They would start their vaccination series. Either they would have no manifestations of the Mpox, or they would actually get a very mild, maybe a single lesion.
Now, so we talked about how people present. What are the treatments once they've been diagnosed with monkeypox? Where do we go from there?
Yeah, so there was a number of treatments that were thought would potentially be effective. And the treatment that we really went forward was tecovirimat. And this Mpox treatment can be oral, mostly oral, can also be done IV. And it actually it looks to be effective. We're waiting for the results of the STOMP Mpox trial, where we'll actually get a little more data. Does it work only in severe? Does it work in severe? Does it work in milder cases? It looks like it works, but at this point, it's hard to sort out, positive experiences, a pile of anecdotes versus the results of that randomized control trial. One of the things I'll say was promising is that we only saw 2 reported resistant viruses in all the thousands of cases that we saw.
Wow. Okay. All right. So I'm assuming, and maybe I shouldn't, you know what they say about assuming, but I'm assuming that people with more comorbidities or immunocompromised are more susceptible or suffer more from Mpox than others, or am I just going off down a rabbit hole?
No, I think you're right there, and it makes sense, and it's what we saw is, compromised immune system is not something great to have with any infection. And we saw some of the worst manifestations in those with compromised immune systems. So thinking about a demographic that there were a lot of cases, men having sex with men. We had some HIV positive individuals, particularly with significant immune compromise, really low CD4 counts, maybe uncontrolled viral loads. Some of those individuals had really severe cases. So, we are worried about individuals who are pregnant. We're worried about children. We're worried about individuals, advanced age. And we're very worried about individuals that do not have an intact, functional, robust immune system.
Right. Are people getting scarring?
So that's a problem, yes. Some of the severe cases have led to scarring. There was a lot of experience before it came to the U.S. With scarring of the eye, so permanent damage to the eye, right? Not something you can quickly fix. And so individuals that have any disease that's close to potentially spreading to the eye would be promptly put on therapy. But some of the areas where the scarring is so bad, we've actually had individuals require reconstructive plastic surgery because the scarring can be that devastating.
Wow. If someone is hospitalized, are they on isolation, or do we need to go that
They
far?
are. They're on contact. They're on droplet. They're on airborne. So it's really the full 9 yards when they're there. And as I mentioned, even though this is really predominantly contact, we have studies where the airplane full of people, one person with active Mpox, no one else gets it. It doesn't spread easily, but you certainly don't want this spreading in a hospital setting. So when we've had patients hospitalized, they're in a private room. It's a negative pressure room, such as we would use for tuberculosis, measles, now at a lot of centers for COVID-19. Everyone is wearing gowns and gloves and all the rest. And the contact transmission is the main concern. So you really want to be properly donning and doffing that personal protective equipment.
Sure. Yeah. What percentage of people, or even an estimate of a percentage of people, are hospitalized, do you think?
It was a larger percent than we initially thought would end up hospitalized. Maybe about 20% of individuals who were diagnosed, right? We're only diagnosing, sort of the more obvious. So the actual, the actual number of infections relative to hospitalization may be a little bit lower. But when you actually look in a lot of these series, about 20% of the individuals that are recognized, diagnosed, end up in the hospital. That's quite a chunk.
Yeah, it is. And if they are sent home, are they instructed to isolate at home, like those who have gotten COVID and had to isolate at home? Because I would think families would be susceptible.
Yeah, the isolation recommendations are going to apply to those who end up in the hospital, also those who don't end up in the hospital. And it's really quite an onerous isolation period. So just to go through the details. So we are recommending that they continue to isolate, not until the lesions are just scabbed over, but till the lesions are completely healed with a new layer of skin. So for some individuals, this really can represent 3 to 4 weeks of isolation. Which is really quite a challenge, right? So, a lot of individuals will basically say, I can't, how am I going to eat? How am I going to get groceries? Fortunately, we have a lot of delivery options, but that's the recommendation. You continue to isolate for that period of time, whether it's 3, 4, 5 weeks. I had one individual before those lesions fully heal and skin, not just scab, but skin over. If that individual is going to go out during that period of time, we're recommending that they wear masks, that they wear gloves, that they do everything they can to prevent spread. Even though we say this is not as easily transmitted as other pathogens, even though this is predominantly significant contact, skin-to-skin contact in general. There can be fomite transmission and other situations. So we really want to prevent it from spreading, and pretty strict isolation recommendations.
Boy, that's got to be tough. I mean, kids, for example. You said that some children have had it, correct?
Yeah, some children have had it. We've had some children here in the local area, and oh my, this is really difficult for them. A lot of telehealth visits. We're glad we have telehealth now, because you really don't want these people traveling about. But yeah, checking in with them, making sure it's going okay. It can be psychologically difficult to isolate that long.
Sure, absolutely. It would be. Thankfully, a lot of people get to work from home now, which is not everyone, though. That's really tough. All right. We have covered a lot of information here in episode 1 that's very informative. We've talked about Mpox that was first noticed to be spreading in humans, symptoms besides the classic rash, testing and treatment, and thankfully there is a low mortality rate. That is good news. So let's continue our conversation with Dr. Griffin. We plan to keep the questions and answers flowing, and also later discuss interprofessional collaboration within the healthcare team. Remember, the healthcare team includes the patient. So we will see you in episode 2. This is Leanna McGuire for Elite Learning, Colibri Healthcare.
This podcast featured content from an accredited CE activity provided by Colibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.
Thank you.